at Children's National Medical Center. I asked her to sort of capture for us in about 10 minutes what the role of nursing is in the care of these injured patients. Once you have these patients, Dr. Maddox has operated on them, all of a sudden they turn this patient over to a nursing team. And so, Jennifer, if you're there, we're looking to your perspective on this. And thank you so much for being here.
I'm here. Can you guys hear me?
Yep.
No, we can't see
Okay.
You can turn on your camera
can't see you.
just above our heads. There's a little button there.
There is no button.
Okay, just go ahead with the talk.
Okay, I apologize. Well, I'm going to talk today just really about the nursing care of the trauma patient. Most of my background has been taking care of these trauma patients, both in the emergency department before you take them to the OR. And the majority of my time has actually been in the intensive care unit post-op taking care of the trauma patients, or for a lot of our kids who never go to surgery during their acute phase. Next slide.
Oh, yeah, Jennifer, a couple things.
Yeah.
I guess you weren't signed in under your name. What name are you signed in under?
I'm sorry, I'm under Matt Otchen.
Ah, okay. We're going to give you all the rights under Matt Otchen, so give us a second here.
Not a problem.
Okay, you should be able to see your camera button now.
Yes.
Okay, and then you also should be able to see the arrows to advance your slides. Under the...
Yes.
There you go.
Perfect. Did the camera go on?
It did not.
Okay. Try
Oh,
one
you have
more
to click
time.
the accept button. If you don't see it, then just go ahead.
Okay, yeah, don't see it. I'm sorry.
Okay, that's all right.
There it is.
Anyway, so our objectives today is to really talk about and define nurse competency, discuss the nursing care of the injured child, identify some of the pitfalls in the nursing world that we fall into, and how all of this really rolls together in order to have a program that allows for quality improvement and our overall goal, patient safety. So the role of the trauma nurse is really clinical competency, communication, family advocacy, and when we do all those three things in sync, we end up providing safe care. When we talk about clinical competency for nursing, it's a little bit different than in the world of medicine. We look at competency as an expected level of performance that results from an integration of knowledge, skills, ability, and judgment. And like in the medicine world, I got no trauma training when I went to nursing school. And so the nurses that are taking care of these patients, they're really getting their competencies from what they learn in orientation to give them a start, but their real knowledge is coming from the experience they get at the bedside, having mentors both in medicine and nursing, getting experience in taking care of different patients. I know my personal experience and most of my knowledge came in participation in rounds and just really asking a lot of questions. Our clinical competency is really a wide breadth when it comes to trauma nursing. There's the knowledge of the anatomy and physiology in order to understand those signs and symptoms and monitoring that we're looking at when we're at the bedside for 12-hour shifts, really being the eyes and ears for the team. As we understand those signs and symptoms, it's understanding why our patient might be tachycardic or confused or not ventilating well. And all this allows us, this understanding is going to allow us to really tailor our care in order to have good patient outcomes, to really look at things such as when do I do pulmonary toileting, how often should I be getting my patient out of bed, how do I improve oxygenation or enhance the ability of a patient to ventilate. Clinical competency also in the nursing realm is focused around medication administration, equipment, and monitoring. And here's the deal. You guys may be pros at inserting that chest tube, but without me at the bedside setting up that thorax, that chest tube may not happen. And it's really the nurse who is going to be there monitoring that collection device, really watching for you at a moment-to-moment notice of what's coming out, be able to do that communication with the medical team as we move forward. the nurse who follows the medication orders with our patients who potentially need antibiotics or sedation. We know what's compatible with other things. If you're running TPN, ask me what's compatible, and I can probably tell you, and we can determine the number of lines and how to get things in effectively and efficiently. The second main role of the trauma nurse is really communication. As a member of the care team, we're often the link between all this ancillary services and the medical team, kind of the glue that holds it together. We're actually the eyes and ears of what's happening moment to moment with the patient, making our communication between the surgeon, the medical team, and the nurse incredibly important. And as long as we can tie in that medical knowledge with our expectations and patient progress and our clinical competence, we'll have the ability to share that data and to really be able to work with the team to be able to move care forward. And lastly, we're often the link with the family. We're the ones sitting with the family during that 12-hour shift and really get to know that family for that unique people that they are. A lot of times we're doing a lot of the explaining. We learn a lot of their customs, their culture, and can be that advocate as we move forward to keeping that patient safe and promoting health. If we break it down to just look at different types of injuries as far as nurse competency and how we move forward for quality of care and patient safety, when we look at the head injured child, a nurse knowing the anatomy and physiology of the brain injury can really tailor their nursing care around the expectations of what may happen with that patient. For instance, if I have a patient with a subdural bleed or DAI, I'm anticipating the fact that over that first 24 hours, I'm going to have increased signs of intracranial pressure. And I'll tailor my nursing assessment and my nursing care to do things such as keep the environment quiet, to keep the TV down, work with the family, to kind of keep them from picking. Keep the patient normothermic, and we'll do interventions to enhance oxygenation, looking at their sedation level and how much oxygen it requires when you have a non-sedated head injured child versus the effects that we can get if we're adequately sedated. The nurse is really responsible for monitoring the ICP or the external ventricular drain. With an EVD, looking at that color and clarity of what's coming out and being able to communicate with the team if we're having changes, and knowing really, do we expect to have changes? Some of the pitfalls of care that we'll have taking care of the head injured patient is as we're trying to promote oxygenation and decrease that ICP, sometimes we can fall in that pitfall of not doing the appropriate care because we're really trying to conserve. And so you find that some of these patients will end up with ventilator-associated pneumonia because we're worried about turning because it increases the ICP. And so we've got to really tailor what we're doing to find that happy medium. And the same goes with sedation. Patient with a thoracic injury, one of the things we're looking at in our competencies is that knowledge of ventilation and oxygenation and how the care we provide can enhance our ventilation and oxygenation or get us into a pitfall. Patients, some of our patients with lung contusions or needing chest tubes, we're constantly looking at how do we improve their ventilation, and as we're watching as we're doing good assessments and we're drawing gases, we may look at how and when to provide pulmonary toileting, get the incentive spirometer out, and maybe as much as how often and when to ambulate, or do we need more sedation because they're in pain and they're not breathing and ventilating as well, or do we need to back off on some of our sedation and let them wake up a little bit and get adequate chest expansion? In management of the chest tube, I really find, yes, we are definitely the eyes and ears to letting you know what the output is, but it's really that knowledge of what that output should be based on the injury we've seen. But the bigger piece is really keeping that chest tube safe. We battle radiology coming in to do x-rays and manipulating the patient, moving him around, that puts our chest tube integrity at risk, parents picking their children up, or even those grubby little fingers of the child themselves that are kind of moving and picking and can A, pull it out, or B, just induce infection to that site. Pitfalls of care when it comes to thoracic injury is really cluster care. A lot of us grew up pretty much doing everything on the hour. In that first 10 minutes of the hour, you go in, do your vitals, do your assessment, do any procedures, and really kind of get it all done. And then we find that we give a report to each other, and we talk about it took 20 minutes for our patient to recover. What we're really finding is that what we did in that first 10 minutes of cluster care has inhibited the oxygenation and ventilation of those patients. And so part of nursing competency is really looking at how do we break up that care and be able to keep our patients well oxygenated, well ventilated throughout that hour and not have those times of recovery. So the other pitfall we can fall into with the thoracic injury is that of complacency. And I talk about complacency in the fact of the dreaded pulse oximeter and the fact that we really can become victims to the monitors in which we sit and look at. And nurses really have to pay just as much attention to our clinical assessment and kind of let our monitors just kind of support that versus taking the lead. We move to abdominal trauma. As far as nurse competency, I look at abdominal trauma anymore as when these patients are taken to the OR, they belong to the surgeon. You guys are doing what it is you do best. But so many of our abdominal traumas right now are nursing managed. They're put on spleen watch or liver watch, and they're managed a lot more conservatively. And so it really is that trauma nurse who is responsible for those serial assessments in between those every 4 or every 6 hour labs that we're doing, and really being in control of paying attention to how that abdomen is feeling, how that child is responding, and being able to identify things early and fast in order to catch problems that may arise. As an ICU nurse, I spent a lot of time taking care of children post-damage control laparotomy and really working with the team as far as managing fluid and preventing infection as we were preparing to take patients back to the OR for their final disposition surgery. Things that we really do and can make a difference with as far as outcomes with those children are, maintaining normothermia, providing airflow warming blankets, administering warm fluid, keeping them warm as that belly is open, and then really providing good communication to the team to help support and return them back. With wound management, we have come a long way with our wound vacs, and it's really helped. But as far as nursing assessment and competency, we're really looking at managing skin care around the site of the wound. We are promoting healing through nutrition and monitoring the output of that wound vac and watching for signs of infection. The pitfalls of care with the abdominal trauma really focus around pain management and the challenges of pain management with young children. In order to make sure you have your pain well managed, yet we're not going overboard. And I think the biggest pitfall of care we can get into is waiting until the day of discharge to really start talking to families about their discharge instructions. There's a lot that goes into discharging a patient with an abdominal trauma. And I find that the earlier we, as nurses, start talking to the families about limitations they'll have, signs and symptoms to watch for, the better prepared they are to go home. My example of that would be on our patients that have been on spleen watch. We send them home day 3, day 4, and there's a lot of do's and don'ts. And it was especially with your teenage kids, when we're talking about activity, the earlier we can start talking to them about the limited activity that they'll have to do and the signs and symptoms to watch for in case they need to return will make a huge difference. As far as extremity injury, as far as nursing competency, neurovascular assessment and pain assessment are key. We all know with compartment syndrome, and I know it was talked about earlier today, that the earlier we identify, the better the outcomes are, and that's a measurable outcome within hospital QI. And so teaching our nurses to really do good neurovascular assessments and to really communicate what their findings are and be very proactive to get people to listen to those neurovascular assessments. And there's things we teach nurses that go well beyond just the feeling for pulses. There's some soft data that we can teach people to do, looking at putting pulse oxes on a good leg and a bad leg to see if both of them are getting perfused well. And we can use those types of data points to really hit home if we start feeling a concern. The other pitfall of care with extremity injury is missed injuries. In trauma, it seems that, at least through the data I look at, is the largest number of missed injuries are some type of fracture. I can give an example of a 3-year-old we took care of who just kept complaining her tongue was hurting and kept complaining it to the nurse. And as we got closer and closer to discharge and she still wouldn't eat, we did find that she had a mandibular fracture. And those are things that just through working with the family, paying attention, talking with the children, and being their advocate, that we can hopefully help identify. Lastly, we have the patient with a burn injury. And as far as competencies with nursing, this is probably the most difficult to teach as far as the pathophysiology of burn progression and the need of the nurse to be able to do hour-by-hour assessments of edema and fluid shift, and to be able to anticipate what truly is going on with the patient. We look at really working with our nursing staff as far as nutrition and the importance of, A, getting people to eat or getting NGs down and being able to get nutrition started in order to promote healing. As nurses, we look at our competency in dressings, identifying the appropriate dressing to put on, how to assess the wound, fluid management, and then really start moving those extremities or those injured areas as soon as they're stable, and keeping things elevated. The pitfall we do follow in is fluid resuscitation, mainly over-resuscitation. What I find is for pretty much everything else, we really like to see as much urine output as we possibly can find, and that all holds true until you get to the burn-injured patient where 5 mils per kilo out an hour is not okay, and a nurse can really lose sight of not staying in tune and keeping that communication up with the physician. The new concepts really to look at is quality improvement, how so many of our nursing interventions and indicators really pull to infection control, early identification of signs and symptoms and complications, and it all pans out really to patient safety and outcome measurement. Communication with your physician and the trauma team is key. And we have advanced practice nurses who really can lead and advance what happens at the bedside and to be able to look at what we're doing at the bedside and the difference it's making in our patient outcomes. That's it.
All right, mic's up.
Mike's up.
Well done.
Jennifer, thank you so much. That was really excellent. It was a great review. And I hope everybody that's listening in see how important nursing is to the whole trauma team and those direct interactions between the patient and the nurse serve many of us in great ways. I think